Welcome to the Deep Dive. Today, we're tackling a topic that's, well, absolutely vital, especially as you're stepping into the world of nursing. Understanding how medications, while intended to heal, can also have unwanted and unexpected effects on the human body. Think of it, these are powerful chemicals interacting with our incredibly complex biological systems, so the outcome isn't always, a straight line from A to B.
That's right. Our goal with medication is always therapeutic benefit, but introducing any chemical into such an intricate environment can set off a chain reaction, and sometimes those reactions aren't the ones we're hoping for.
Right.
They can range from simply unpleasant to potentially quite dangerous.
Exactly. So in this deep dive, we're going to break down the different types of these adverse drug reactions, explore the reasons behind them, and really get a solid grasp on why this knowledge is so crucial, particularly for those of you embarking on your nursing careers.
This is foundational for nurses. You are the ones at the forefront administering medications, providing direct patient care. Your ability to recognize the clues, the signs and symptoms that might indicate an adverse drug reaction, and your understanding of how to respond effectively are absolutely essential for keeping your patients safe and, well, improving their overall treatment journey.
Okay, let's get right into it then. What exactly is an adverse drug reaction? What are we talking about here?
At its heart, an adverse drug reaction, often shortened to ADR, is any unwanted effect that happens as a result of taking a medication.
Oh, okay.
These effects can be as mild as a bit of nausea or as severe as a life-threatening allergic response.
And why do these reactions occur? It seems almost paradoxical when we're giving a medication to help someone get better.
Well, there are several reasons. Sometimes the drug has effects that extend beyond its specific therapeutic target. It might interact with other systems or pathways in the body that we weren't aiming for.
Okay.
Other times, an individual patient might have a unique sensitivity to a particular drug. Then, there are situations where the very way a drug works in the body, even if its main action is beneficial, can trigger undesirable responses. And of course, dosage plays a critical role. Too much or too little medication can both lead to problems.
So it's not always a case of the drug being inherently bad, but more about the incredibly complex interaction with each person's unique body chemistry.
Precisely. And this is where your role as a nurse becomes so critical. You need to be constantly observant, always looking for any indication that a patient might be experiencing an adverse reaction. It's not just about giving the pill, it's about the ongoing assessment of how that patient is responding.
And it's not just about what we see ourselves, right?
Yeah.
Patient and family education must be a huge part of this.
Absolutely. Patients need to be informed, empowered, really, to recognize potential adverse effects when they're taking medications at home. Knowing what to watch out for and understanding when and how to report it to their healthcare providers is absolutely vital.
And it sounds like having this understanding can actually help patients stick with their treatment plans too. If they know what to expect, maybe they're less likely to get discouraged by side effects.
That's a very insightful point. Yes. When patients understand that certain side effects are a possibility and they have strategies for managing them, or know when a side effect warrants seeking medical attention, they are far more likely to adhere to their medication regimen. It builds trust and reduces anxiety.
Okay. So we have this big umbrella term, adverse drug reactions. How do we further categorize these different types of reactions?
We can generally classify adverse drug effects into three main categories: primary actions, secondary actions, and hypersensitivity reactions, which are also known as drug allergies.
Okay, let's start with primary actions. What are those all about?
Primary actions are essentially exaggerated therapeutic effects. Think of it as the drug doing exactly what it's supposed to do, but doing it, well, too intensely. The most common cause of this is simply getting too much of the medication and overdose.
Can you give us a clear example of that?
Certainly. Let's take an anticoagulant, a medication used to thin the blood and prevent blood clots. Its primary action is to reduce the body's ability to form clots, right? However, if the dose is too high, this primary action can be amplified to the point where the patient experiences excessive and even spontaneous bleeding.
Wow, that sounds quite serious. How do healthcare providers work to prevent something like that from happening?
Careful monitoring is key. Regular blood tests to assess the patient's blood clotting ability allow healthcare providers to fine-tune the prescribed dose to meet that specific patient's individual needs.
Right.
What might be the right amount for one person could be too much or too little for someone else,
That really highlights the importance of tailoring treatment to the individual. Are there other factors that can influence how strongly a drug's primary action is felt?
Absolutely. Individual responses can vary quite a bit. Factors such as a patient's weight, their age, and any other health conditions they have can all impact how a drug affects them, potentially requiring adjustments to the standard dose. For instance, a typical dose of a blood pressure medication might cause some individuals to feel excessively dizzy, weak, or even faint. In such cases, a lower dose might be necessary for them to tolerate the therapy comfortably.
And what about how well a person's organs are functioning? I imagine that can significantly affect how drugs are processed by the body.
That's a critically important point. Consider a patient who has kidney problems. The kidneys are responsible for filtering many drugs out of the bloodstream, right?
Mm-hmm.
If the kidneys aren't working efficiently, the drug can build up in the body, leading to exaggerated adverse effects even if the dose given was within the normal range. The body simply isn't clearing the medication as it should.
Okay, so the filter's clogged, basically.
Exactly. Think of your kidneys as the body's filtration system for drugs. If that filter is clogged, the medication levels can skyrocket, turning a helpful dose into a harmful one surprisingly quickly.
Yeah, it makes perfect sense. Okay, so that's primary actions, essentially. The drug doing too much of what it's meant to do. Now, what about secondary actions?
Secondary actions are effects that a drug has on the body that are not related to its main therapeutic purpose. These are often referred to as off-target effects.
And are these secondary actions always negative?
Not always entirely negative, but they're usually undesired in the context of the primary treatment. Sometimes we can adjust the drug dose to try and minimize these secondary reactions while still achieving the desired therapeutic effect.
But not always.
No, sometimes they are almost unavoidable no matter how carefully we manage the dosage.
So in those cases where they can't be entirely avoided, what's the strategy?
That's where comprehensive patient education becomes absolutely paramount. If we know that a particular drug is likely to cause certain secondary effects, we need to inform the patient that these may occur and provide guidance on how to best manage them.
Can you give us a common example of a secondary action that nurses frequently encounter?
Sure. Think about antihistamines, commonly used for allergy relief. Their primary action is to block histamine, which helps to dry up nasal secretions and relieve other allergy symptoms.
Right, like Benadryl.
Exactly, but a very common secondary action of many antihistamines is drowsiness. Patients taking these medications need to be clearly advised about this potential side effect and understand that they should avoid activities that require alertness, such as driving or operating heavy machinery, until they know how the medication affects them personally.
That's a classic example, yeah. Many people are familiar with that one. What are some other common secondary actions that nurses should be particularly aware of?
Gastrointestinal side effects are quite common with many medications. For example, oral antibiotics, while targeting bacterial infections, can also disrupt the normal balance of bacteria in the gut. This disruption can lead to diarrhea, nausea, and sometimes vomiting. Advising patients to eat smaller, more frequent meals can often help to alleviate these types of problems.
It seems like individual responses play a role here as well, much like with primary actions.
Absolutely. Each person's body is unique, with slightly different receptors and cellular responses. This can lead to variability in how individuals experience both the intended therapeutic effects and the secondary effects of a drug. A fascinating example of this is how some older adults sometimes react to narcotic pain medications. Instead of the expected sedation and pain relief, they might experience increased stimulation and even hyperactivity.
Yeah, hyperactivity.
Yeah. It's thought that this might be due to age-related changes in their receptors, leading to an altered sensitivity to the drug's effects.
Wow. That's certainly something vital to keep in mind when providing care for older adult patients. Okay, now let's move on to the third category. Drug allergy or hypersensitivity. This sounds quite different in that it involves the body's immune system.
It is indeed different. Drug allergies or hypersensitivities involve the body's immune system mistakenly identifying a drug as a harmful invader.
Okay.
When a person is first exposed to a particular drug, their body can sometimes recognize it as foreign and produce antibodies against it.
So it's like the body is mounting an immune response, similar to how it would react to a virus or a bacteria.
Exactly. And then, the next time the person is exposed to that same drug, these preformed antibodies trigger an immune response, which then manifests as the signs and symptoms of an allergic reaction.
That makes it clear why someone can't be allergic to a drug they've never taken before.
Yeah.
Their body hasn't had that initial exposure needed to build up those specific antibodies.
Precisely. However, it's really important to understand that patients can have what we call cross allergies.
Cross allergies.
Yes. This means if someone is allergic to one drug within a particular class of medications, they might also have an allergic reaction to other drugs within that same class, even if they haven't taken those specific drugs before. The immune system recognizes similarities in their chemical structures.
That's a crucial point to remember when taking a patient's allergy history. I can also imagine that it's really important for nurses to be able to distinguish between a true drug allergy and, say, a predictable side effect of a medication.
Absolutely vital. As we touched on earlier with secondary actions, many people might report a drug allergy simply because they experienced an unpleasant side effect.
Right.
For example, a patient might say they're allergic to a diuretic like furosemide because it made them urinate more frequently. But increased urination is the intended effect of a diuretic, not an allergic reaction.
Okay.
So as a nurse, it's essential to ask very specific questions to understand the exact nature of the patient's response and determine if it was a true immune-mediated allergy or just a known pharmacological effect.
So if it's determined to be a true drug allergy, are all allergic reactions the same in terms of how they present?
Not at all. Drug allergies can vary significantly in terms of how quickly they occur after exposure to the drug and how severe the reaction is. Some reactions are immediate, happening within minutes of taking the medication, while others might take hours, days, or even weeks to develop.
Wow.
And the level of severity can range from mild and irritating, like a localized rash, to severe and life-threatening, such as anaphylaxis.
You mentioned anaphylaxis, which sounds like a very serious and rapid reaction. Is that related to a specific type of allergic reaction?
Yes, anaphylaxis is the most severe form of a type I hypersensitivity reaction. Drug allergies are generally classified into four main types. Type 1, which we call immediate hypersensitivity disorders. Type 2, antibody-mediated disorders. Type 3, immune complex-mediated disorders. And Type 4, cell-mediated hypersensitivity disorders.
Okay, 4 types.
Right. Each type involves a different part of the immune system and has its own unique mechanisms and clinical manifestations. You know, while all allergies involve a mistaken immune response, understanding the type of response is kind of like knowing whether the fire is a grease fire, like a type I needing rapid suppression, or a slow burn, maybe a type 5, requiring long-term management.
Okay, let's break down these different types of allergic reactions, starting with type I, the immediate hypersensitivity. What exactly is happening in the body during this type of reaction?
Okay, type I reactions involve a specific type of antibody called immunoglobulin E, or IgE. On the first exposure to the drug allergen, IgE antibodies are produced and attach themselves to specialized cells called mast cells and basophils, which are found throughout the body. Upon subsequent exposure to the same drug, the allergen binds to these IgE antibodies that are now attached to the mast cells and basophils. This binding triggers these cells to rapidly release a flood of inflammatory chemicals, such as histamine.
And what are the typical signs and symptoms that a nurse might observe in a patient experiencing a type I reaction? You mentioned anaphylaxis earlier.
These reactions often develop very quickly and can be quite dramatic. Symptoms can include hives, a widespread itchy rash, difficulty breathing, a sudden drop in blood pressure that can fluctuate rapidly, what we call labile blood pressure, dilated pupils, excessive sweating, diaphoresis, a feeling of intense anxiety or panic, and an increased heart rate. In the most severe cases, this can progress to respiratory arrest, where the patient stops breathing, and anaphylaxis, a life-threatening systemic allergic reaction affecting multiple body systems.
What are the immediate nursing interventions if a nurse suspects a type I reaction, especially in the case of anaphylaxis? That sounds critical.
It is. Anaphylaxis is a medical emergency that requires immediate action. The very first and most crucial intervention is to immediately stop the administration of the suspected allergen, withdraw the medication.
Right away.
Right away. Then administer epinephrine, which helps to counteract the effects of the histamine and other inflammatory mediators that have been released. Ensuring the patient has a clear airway and providing support for their blood pressure are also absolutely critical.
Okay.
For less severe, localized type I reactions, simply stopping the medication and administering over-the-counter antihistamines and odor decongestants might be sufficient.
And prevention is obviously key for patients with known severe allergies. What should nurses reinforce with these patients?
Absolutely. Patients with known severe allergies should be strongly advised to wear medical identification, like a medical alert bracelet or necklace, so that healthcare providers are immediately aware of their allergy in an emergency, even if the patient can't communicate.
Good point.
If appropriate, they should also have an emergency epinephrine auto-injector, like an EpiPen, readily available at all times and be thoroughly educated, along with their family members, on how and when to use it.
Moving on to type 2, the antibody-mediated disorders. How do these allergic reactions differ from the immediate type I reactions?
Well, type 2 reactions involve different types of antibodies, typically immunoglobulin G, IgG, or immunoglobulin M, IgM. These antibodies circulate in the bloodstream and target antigens, which are specific molecules that are present on the surface of the body's own cells.
On our own cells.
Yes, this antibody-antigen interaction leads to the destruction of those cells.
And is this type of reaction as rapid in onset as the type I reactions?
No, type 2 reactions are generally not immediate. They typically take some time to develop, often a few days to a week or even longer, after exposure to the drug that triggers the reaction.
What kind of signs and symptoms might a nurse observe in a patient experiencing a type 2 reaction, if it affects different cells?
Exactly. The specific signs and symptoms will really depend on which particular cells or tissues in the body are being targeted and destroyed by the antibodies. For example, if the antibodies are directed against kidney cells, it could lead to kidney dysfunction or even failure. If they attack liver cells, it could result in liver dysfunction and signs of hepatitis. In some cases, type 2 reactions can even manifest with symptoms that mimic certain autoimmune disorders like hyperthyroidism or myasthenia gravis, where the body's immune system mistakenly attacks its own healthy tissues.
What are the priority nursing interventions if a type 2 reaction is suspected in a patient?
The very first step is to immediately notify the prescribing healthcare provider and discontinue the suspected drug that is triggering the reaction.
Stop the drug.
Yep. Following that, the primary focus shifts to providing supportive care for the patient. This might involve taking measures to prevent infection, which the body might be more susceptible to due to the immune response, and helping the patient conserve energy until the allergic response subsides.
Now let's talk about type 3 reactions, the immune complex mediated disorders. What's the underlying mechanism behind these types of allergic responses?
Type 3 reactions also involve IgG and IgM antibodies circulating in the bloodstream. However, in this case, instead of directly attacking cells, these antibodies bind to the drug antigen to form what we call immune complexes.
Immune complexes?
Yeah, these complexes are too large for the body to easily clear, so they tend to deposit in various tissues throughout the body, particularly in the walls of blood vessels. The deposition of these immune complexes then triggers inflammation and can lead to tissue damage in the affected areas.
And how long after exposure to the drug does it typically take for a type 3 reaction to develop and become noticeable?
These reactions can take a bit longer to manifest compared to type I and II reactions. It might take anywhere from 1 to 3 weeks, or even longer in some cases, after exposure to the drug for the immune complexes to form and deposit in tissues, leading to noticeable symptoms.
What are the common signs and symptoms that a nurse might observe in a patient experiencing a type 3 reaction?
Common signs include an itchy skin rash, often with small, raised bumps, a high fever, swollen lymph nodes, swollen and painful joints, and edema, which is swelling, particularly in the face and limbs.
Okay.
If the reaction involves more widespread symptoms throughout the body, it's often referred to as serum sickness, because the initial research on this type of reaction involved serum. The key is that these antibody-antigen reactions are happening in the bloodstream and can damage blood vessels throughout the body, leading to these systemic symptoms.
What is the primary focus of nursing care for a patient who is experiencing a type 3 allergic reaction?
Similar to type 2 reactions, the initial steps are to promptly notify the healthcare provider and discontinue the drug that is suspected of causing the reaction.
Again, stop the drug.
Yes. Following this, the focus of nursing care is on providing comfort measures to help the patient manage the various signs and symptoms. This can include creating a cool and comfortable environment, ensuring meticulous skincare for the rash, promoting comfortable positioning, applying ice packs to swollen joints, and administering prescribed meds like antipyretics for fever and anti-inflammatories for pain.
Finally, we have type IV reactions, the cell-mediated hypersensitivity disorders. How are these fundamentally different from the other 3 types of allergic reactions we've discussed?
Type IV reactions are unique because they don't involve antibodies at all. Instead, they involve specific types of T cells, which are a type of white blood cell central to cell-mediated immunity.
T cells, okay.
In a type IV reaction, when the individual is exposed to the drug antigen, it activates these specific T cells. These activated T cells then either directly cause cell death in the affected tissues or release chemical messengers called cytokines, which lead to a delayed inflammatory response.
And what is the typical time frame for the appearance of a type IV reaction after exposure to the drug? You said delayed.
Right. Type IV reactions are characterized by their delayed onset. They typically don't appear until several hours to even days after the individual has been exposed to the drug. This delayed response is a key distinguishing feature.
What kind of signs and symptoms might a nurse observe in a patient experiencing this type of delayed hypersensitivity reaction?
The clinical manifestations can vary depending on where the reaction is occurring. A very common presentation is an itchy skin rash, maybe with hives or blisters and potentially swollen joints. This is often seen in contact dermatitis, say, from topical medications.
Oh, like poison ivy, but from a drug.
Kind of, yeah. If the reaction occurs in the lungs, the patient might have difficulty breathing and a persistent dry cough. If liver cells are targeted, there could be signs and symptoms of liver inflammation, similar to hepatitis.
What are the key nursing interventions for a patient experiencing a type 5V hypersensitivity reaction?
Once again, first step, notify the prescriber, discontinue the suspected drug. For skin reactions, provide meticulous skin care and comfort measures, maybe topical corticosteroids or oral antihistamines. If there are more widespread or systemic reactions, the patient might need more advanced medical management.
So, across all these different types of allergic reactions, it sounds like the nurse's role consistently involves careful assessment, being able to recognize the specific signs and symptoms of each type, and being ready to intervene appropriately based on those findings.
Precisely. Your vigilance, your thorough understanding of these different reaction types, and your prompt, appropriate responses can truly make a significant difference in patient outcomes.
Now let's shift gears a little bit and talk about drug-induced tissue and organ damage. It's a sobering thought that medications designed to help and heal can sometimes inadvertently cause harm to our tissues and vital organs.
It is a sobering thought, but it's also a critical aspect of pharmacology that every healthcare professional, especially nurses, needs to thoroughly understand. Drugs can cause damage through a couple of main pathways, either directly through their inherent toxic effects on cells, or indirectly by interfering with normal physiological processes in a way that leads to damage.
Right.
This is precisely why we see contraindications and cautions listed for using certain drugs in patients with specific pre-existing health conditions.
So as nurses, we need to be knowledgeable not just about the intended therapeutic effects, but also keenly aware of the potential for harm to different parts of the body.
Exactly. You need to develop a strong understanding of how this damage might present clinically in your patients and what nursing interventions are appropriate should it occur. And we see this potential for drug-induced damage across, well, virtually all body systems.
Let's begin by discussing dermatological reactions, since the skin is often the most visible indicator that something might be going wrong with the medication.
Dermatological reactions are indeed among the more common adverse effects. These reactions can range from a relatively mild, localized skin rash to very severe, potentially life-threatening conditions like exfoliative dermatitis and Stevens-Johnson syndrome.
Wow.
Many different drugs can either deposit in the skin itself, causing a direct reaction, or trigger systemic immune responses that manifest as skin problems.
You mentioned a couple of specific and serious conditions.
Yeah.
Exfoliative dermatitis and Stevens-Johnson syndrome. What are the key features nurses should look for when assessing dermatological reactions?
It's important to pay close attention to the appearance and distribution of any skin changes. Look for hives, different types of rashes, flat, raised, blistering, peeling, and any other unusual skin lesions. In more severe cases, be particularly alert for signs of exfoliative dermatitis, which involves a widespread red rash and significant scaling or peeling of the skin. This often comes with systemic symptoms like fever, enlarged lymph nodes, and maybe an enlarged liver.
As Stevens-Johnson.
Stevens-Johnson syndrome is another severe one. It typically presents with dark red papules, small raised bumps, often in characteristic ring-like patterns, mainly on the extremities and trunk. Interestingly, unlike many itchy rashes, the lesions of Stevens-Johnson usually don't cause significant itching or pain, which can be a key differentiator.
That's interesting. And what are the essential nursing interventions for these different levels of severity?
For mild reactions, or where the drug's benefit outweighs the discomfort, the focus is on meticulous skin care. Advise the patient to avoid irritation, no rubbing, tight clothes, harsh soaps. Antihistamines can help with itching. In severe reactions like exfoliative dermatitis or Stevens-Johnson, the offending drug needs to be stopped immediately and the prescriber notified without delay. Management often involves topical corticosteroids, antihistamines, and emollients for moisture. Supportive care for fluids, electrolytes, and infection prevention is also critical.
Moving from the external to the internal, let's discuss stomatitis. What exactly is that, and which types of drugs are prone to causing it?
Stomatitis refers to a general inflammation of the mucous membranes lining the mouth. It can happen from a direct toxic effect of certain drugs on the rapidly dividing cells of the oral mucosa, or because some drugs deposit in the small blood vessels there, causing inflammation. Antineoplastic drugs, chemotherapy drugs, are particularly well known for causing stomatitis as a common side effect because they target rapidly dividing cells everywhere.
What are the key assessment findings for stomatitis? What should a nurse look for?
During your oral assessment, look for swollen, inflamed gums, gingivitis, and a swollen, reddened tongue, glossitis. Patients might also report difficulty swallowing, persistent bad breath, and complain of pain or burning in their mouth and throat.
And what are the important nursing care measures for patients experiencing stomatitis?
Meticulous and frequent mouth care using a non-irritating solution is absolutely crucial. We also need to carefully evaluate their nutrition, as eating can become very painful.
Right.
We need to work with the team to develop a diet they can tolerate, often small, frequent meals, bland and soft. A dental consult might be needed sometimes. Antifungals might be used if a fungal infection develops, and local anesthetic rinses can sometimes help with pain relief for eating.
Gastrointestinal irritation seems like a fairly common complaint with many medications. What are the typical mechanisms, and what signs should nurses be aware of?
Some drugs cause direct local irritation. For example, NSAIDs can reduce the protective mucus lining in the stomach, increasing the risk of heartburn, indigestion, even ulcers. Other meds might directly stimulate the chemoreceptor trigger zone in the brain, leading to nausea and vomiting. And some drugs affect GI motility. Opioids, for instance, slow down peristalsis, frequently causing constipation.
What are the key assessment findings and interventions for GI irritation?
Assessment involves asking about nausea, vomiting, bowel movement frequency and consistency for diarrhea or constipation, heartburn, indigestion, bloating, or discomfort.
Okay.
Interventions often include advising patients to take meds with food that can buffer the GI tract. For constipation, maybe motility stimulants or stool softeners. If nausea and vomiting are significant, antiemetics might be ordered.
Let's move on to superinfections. That term always sounds a bit ominous. What does it really mean in this context?
Yeah, it can sound concerning, but understanding the process is key. Our bodies have a natural community of microorganisms. Bacteria, fungi, our normal flora. They live on our skin, in our gut, and actually help protect us. However, certain meds, especially broad-spectrum antibiotics that kill a wide range of bacteria, can disrupt this balance by killing off good bacteria, too.
Collateral damage.
Exactly. This disruption creates an opportunity for other microorganisms, often resistant ones or ones not usually present in large numbers, to overgrow and cause a new infection that's a superinfection.
What are some telltale signs that a patient might have developed a superinfection?
You should be alert for new symptoms that weren't there with the original infection. Maybe a new onset of fever, diarrhea, a black or hairy-looking tongue, an inflamed tongue, glossitis, new lesions on mucous membranes, mouth or vagina, or vaginal discharge, sometimes with itching.
And how are superinfections typically managed?
Management is mainly supportive care for the symptoms. Meticulous mouth and skin care, easy bathroom access for diarrhea, small, easily digestible meals. If it's fungal, antifungals will be prescribed. In severe cases, it might be necessary to stop the original antibiotic that triggered it.
Now, let's talk about blood dyscrasia. Sounds like it directly involves blood abnormalities. What does it mean regarding adverse drug reactions?
Yes, blood dyscrasia is a general term for abnormalities in blood cell components. In the context of ADRs, it usually means bone marrow suppression caused by certain medications.
Bone marrow suppression.
Right. The bone marrow produces our blood cells, red cells, white cells, platelets. Certain drugs, especially chemo agents and some antibiotics, can interfere with these rapidly dividing cells in the marrow.
So if the bone marrow is suppressed, what assessment findings would suggest blood dyscrasia?
Symptoms can be varied. Fever, chills, persistent sore throat, unexplained weakness, fatigue, back pain, maybe dark urine. Blood tests are essential and will show decreased levels of one or more cell types, low hematocrit hemoglobin anemia, low platelets, thrombocytopenia, low white blood cells, leukopenia. Severe cases might show a reduction in all elements, pancytopenia.
And how are blood dyscrasias managed? What kind of nursing care is important?
Close and frequent monitoring of complete blood counts is essential. Nursing care focuses on supportive measures, ensuring rest, minimizing infection exposure due to low WBCs, Preventing injury, low platelets mean higher bleeding risk, avoiding risky activities. In severe cases, the provider might stop the drug or hold treatment until counts recover.
Let's move on to the broader concept of toxicity. When do we generally classify an adverse effect as toxic?
In general, toxicity refers to serious, potentially life-threatening adverse reactions to a drug. When a drug is known to have potential for toxic effects, providers must carefully weigh the benefits against the significant risks of causing serious, potentially irreversible harm.
We often hear terms like hepatotoxicity and nephrotoxicity. Let's start with hepatotoxicity damage to the liver.
The liver is particularly vulnerable for a couple of reasons. First, the first-pass effect. Oral drugs go straight from the gut to the liver before general circulation, exposing liver cells to high concentrations. Second, the liver metabolizes most drugs, and some metabolic byproducts can be irritating or toxic to liver cells. Plus, taking multiple hepatotoxic drugs together significantly increases the risk.
How do providers typically monitor for hepatotoxicity?
Regular monitoring of liver function tests, LFTs, blood tests measuring liver enzymes like AST and ALT, and bilirubin is crucial for patients at risk. Even subtle enzyme elevations can be an early warning sign.
What are the specific signs and symptoms of hepatotoxicity nurses should watch for?
Initial symptoms can be vague, maybe fever, malaise, nausea, vomiting. Then, noticeable jaundice, yellowing skineys, dark urine, pale stools, upper abdominal pain. Later, LFTs will show elevated enzymes, altered bilirubin, maybe changes in clotting factors like PTT.
And what are the immediate nursing interventions if hepatotoxicity is suspected?
First step, immediately notify the prescriber. If damage is significant, the drug will likely be stopped. Nursing care focuses on supportive measures: small, easy-to-digest meals, good skin care for itching if jaundice is present, cool environment, rest to reduce liver demands.
Now let's turn to nephrotoxicity, kidney damage from medications.
Right. Meds can harm kidneys in various ways, constricting blood vessels, causing direct toxic damage to tubule cells, or even obstructing urine flow. Both the original drug and its metabolites can damage the nephrons, the kidney's filtering units. Gentamicin, an antibiotic we mentioned earlier, is a well-known example with nephrotoxicity risk.
What assessment findings might suggest nephrotoxicity?
You might see elevated BUN and creatinine levels in blood tests, key kidney function indicators. Other signs could include decreased urine output, electrolyte imbalances, fatigue, malaise, edema, swelling, irritability, maybe a rash.
And the nursing interventions if nephrotoxicity is suspected.
Again, first step, promptly notify the prescriber. The drug may need to be stopped. Nursing care involves supportive measures, careful positioning, managing fluid intake and diet restrictions, meticulous skin care, monitoring and correcting electrolytes, promoting rest, maintaining a controlled environment. In severe cases, dialysis might be needed.
We also need to briefly touch on poisoning in the context of medications. How's that generally defined?
Medication poisoning usually occurs with an excessive dose, causing damage to multiple systems, potentially fatal reactions. The signs, symptoms, and treatment vary hugely depending on the drug, amount, and patient status.
Okay.
Pharmacology resources often list specific antidotes or treatments. Severe poisoning often requires immediate emergency and life support. Nurses play a critical role in initial assessment, supportive care, and administering prescribed antidotes or treatments.
Let's move on to how medications can affect glucose metabolism, potentially leading to hypoglycemia or hyperglycemia.
Right. Glucose is the body's main energy source, especially for the brain. Its regulation involves hormones like insulin and glucagon, enzymes, and the liver. Many drugs can impact blood glucose by affecting the liver or the endocrine system.
Let's start with hypoglycemia, low blood sugar. Which drugs are more likely to cause this?
Certain diabetes medications like insulin itself and oral drugs like glipizide or glyburide are designed to lower glucose. But if the dose is too high or taken without enough food, they can lower it too much.
What are the signs and symptoms of hypoglycemia nurses should watch for?
Early symptoms can be varied: fatigue, drowsiness, excessive hunger, anxiety, headache, cold, clammy skin. As it drops further, shakiness, lack of coordination, increased heart rate BP, numbness, tingling around the mouth lips, confusion, rapid shallow breathing. Severe cases can lead to seizures or coma.
What are the immediate nursing interventions for suspected hypoglycemia?
The primary goal is to quickly restore blood glucose, if conscious and able to swallow. Give sugar juice, regular soda, glucose tablets. If unable to take orally, 4V glucose might be needed, as prescribed.
Okay.
Supportive measures: skin care, comfortable environment, rest. Safety measures for falls are crucial if confused or unsteady. Monitor glucose levels closely, offer reassurance.
Now, let's consider hyperglycemia, high blood glucose, as a potential side effect.
Certain drugs can stimulate glucose release from the liver or increase insulin resistance. Prednisone, a common corticosteroid, is a well-known example. It makes the body less sensitive to insulin.
What are the typical signs and symptoms of drug-induced hyperglycemia?
You might see fatigue, frequent urination, polyuria, excessive thirst, polydipsia, deep rapid breathing, Kussmaul respirations, restlessness, increased hunger, polyphagia, nausea, hot flushed skin, maybe a foody breath odor indicating ketones.
And how is drug-induced hyperglycemia managed? Nursing care.
Management usually involves insulin therapy, as prescribed, to lower glucose levels, plus frequent glucose monitoring. Supportive nursing care. Easy bathroom access, help regulating temperature, reducing stimulation if restless, reassurance, good oral care for dry mouth, bad breath.
Medications can also significantly impact electrolyte balance. You mentioned potassium is critical. Let's discuss both hypokalemia, low potassium, and hyperkalemia, high potassium.
Yes, because drugs influence chemical reactions, they can impact electrolyte levels. Potassium is vital for nerve and muscle function, especially the heart. Even small deviations can have big consequences.
Let's start with hypokalemia, low potassium. Which drugs are more likely culprits?
Certain drugs affecting the kidneys can cause potassium loss. Loop diuretics, like furosemide, are a prime example. They increase sodium and water excretion, but also promote potassium loss in urine.
What are the key signs and symptoms of hypokalemia?
Symptoms include serum potassium below normal, usually 3.5 millieql, muscle weakness, numbness, tingling in extremities, muscle cramps, nausea, vomiting, diarrhea, decreased bowel sounds, irregular weak pulse, orthostatic hypotension, disorientation. Severe cases can lead to paralytic ileus.
And how is hypokalemia managed? Nursing care.
Primary treatment is potassium replacement oral supplements or IV infusion. Monitor serum potassium and clinical response closely during replacement. Watch for overcorrection leading to hyperkalemia. Supportive care, safety precautions for weakness, dizziness, reorientation if confused, comfort measures. Cardiac monitoring might be needed due to arrhythmia risk.
Now let's discuss hyperkalemia, high potassium. What causes this?
Drugs affecting kidneys differently, like potassium-sparing diuretics, spironolactone, can cause potassium retention. Also, drugs causing significant cell death, like chemo agents, release potassium from damaged cells into the blood.
What are the typical signs and symptoms of hyperkalemia?
Symptoms include serum potassium above normal, 5 millieql, muscle weakness, muscle cramps, diarrhea, numbness, tingling, slow heart rate, low BP, decreased urine output, difficulty breathing.
And how is hyperkalemia managed? Nursing consideration.
Management focuses on rapidly decreasing serum potassium. Meds like patiromer bind potassium in the GI tract. Monitor closely for overcorrection, hypokalemia. Supportive measures. Safety for weakness, comfort, continuous cardiac monitoring. High risk of dangerous arrhythmias. Be prepared for a cardiac emergency. Severe cases might require dialysis.
Let's turn now to sensory effects impacting vision and hearing. These are crucial for patient safety and quality of life.
Absolutely right. Alterations in vision or hearing create significant safety risks, falls, difficulty interacting with the environment.
Starting with ocular damage, which drugs might affect the eyes, and what assessments are key.
The retina's blood vessels are tiny end arteries, vulnerable to damage. Some drugs deposit in these vessels, causing inflammation. Chloroquine, used for rheumatological diseases and malaria, is known for potential retinal damage, even blindness.
What are the specific signs of ocular damage?
Be alert for complaints of blurred vision, changes in color perception, signs of corneal damage, in severe cases, progressive vision loss or blindness.
Essential nursing interventions for potential ocular toxicity.
Careful, regular vision monitoring, maybe charts, or just asking about changes. If concerns arise, consult the prescriber immediately. The drug might need stopping. For irreversible vision loss, supportive measures are key. Adjusting lighting, advising on managing different light conditions, sun protection if needed.
Now, auditory damage. What parts of the ear can be affected, and which drugs are common culprits?
The inner ear structures for hearing and balance, including the 8th cranial nerve, is susceptible. High doses of macrolide antibiotics, like erythromycin, and aminoglycosides, like gentamicin, are known for potential severe, sometimes permanent, auditory damage.
Even aspirin?
Yes, even aspirin, especially high doses, is linked to tinnitus, ringing in the ears, and other 8th nerve effects.
Key assessment findings for drug-induced auditory damage. What should nurses listen for?
Be attentive to reports of dizziness, tinnitus, imbalance, difficulty with coordination, or subjective hearing loss difficulty understanding conversations.
And important nursing interventions if auditory damage is suspected.
Monitor for perceptual losses, hearing balance. Implement safety measures for falls if dizzy. Promptly consult the prescriber. Dose reduction or discontinuation might be needed. Provide supportive measures for any hearing balance impairments.
Finally, let's delve into neurological effects, a broad category affecting peripheral nerves and the CNS.
It is broad. Many drugs affect nerve function directly via pharmacology or indirectly by altering electrolytes or glucose needed for nerve function.
What are some general CNS effects commonly seen as adverse reactions?
Although the blood-brain barrier offers protection, some drugs cross it. Some are CNS stimulants, others depressants. Even corticosteroids can cause mood behavior changes, irritability, restlessness, insomnia.
Specific signs and symptoms of these general CNS effects.
Be alert for confusion, delirium, insomnia, or drowsiness, changes in reflexes, hyperflexia, bizarre dreams, hallucinations, numbness, tingling, paresthesias, even seizures.
General nursing interventions for these neurological side effects.
Safety is top priority, especially with altered mental status or coordination. Fall precautions. Caution against dangerous activities like driving if drowsy or confused. Frequent orientation. Emotional support. Crucially, consult the prescriber. Dose adjustment or stopping the drug might be needed.
Let's get into specific neurological effects, starting with anticholinergic effects. What are these? Which drugs cause them?
Anticholinergic effects happen when drugs block acetylcholine, a key neurotransmitter in the parasympathetic rest and digest system. Atropine is a classic example, but many common drugs, some cold remedies, antihistamines, antidepressants, have these effects.
Common signs and symptoms of anticholinergic side effects.
It's a broad range. Dry mouth, sometimes altered taste, difficulty swallowing, heartburn, constipation, bloating, urinary hesitance, retention, blurred vision, photophobia, light sensitivity, headache, confusion, nasal congestion, rapid heartbeat palpitations, decreased sweating, dry warm skin, maybe even ileus.
Nursing interventions to help manage these uncomfortable effects.
For dry mouth, sips of water, sugarless lozenges, oral hygiene, constipation, fluids, fiber, maybe a bowel program, blurred vision, caution with activities, sunglasses for photophobia, headache, congestion, maybe OTC meds. Advise voiding before taking the med, stay hydrated, warn about overheating risk due to less sweating.
Another important set, extrapyramidal symptoms, EPS. What are these and which drugs cause them?
EPS are movement-related side effects, often resembling Parkinson's features. They usually result from drugs, especially antipsychotics like haloperidol, that affect dopamine levels, crucial for motor control.
Different types of EPS a nurse might observe.
You might see lack of movement slowness, akinesia, tremors, drooling, gait changes, rigidity, restlessness, akathisia, or involuntary muscle spasms, abnormal movements, dyskinesias. Usually these lessen or resolve once the drug is stopped.
How are EPS managed? Nursing considerations.
If severe or outweighing benefits, the provider might start the drug or switch. Sometimes other meds, anticholinergics, anti-Parkinson drugs, are used to counteract EPS. If swallowing is hard, small frequent meals, upright position. Safety precautions if balance gait affected.
Finally, neuroleptic malignant syndrome, NMS. Sounds very serious.
Yes, NMS is rare but potentially fatal, triggered by general anesthetics and other CNS drugs affecting dopamine, like metoclopramide and some antipsychotics.
Key assessment findings for suspected NMS.
Be alert for rapid onset of neurological symptoms, slowed reflexes, severe muscle rigidity, involuntary movements, often with hyperthermia, very high fever, autonomic instability too, fluctuating high BP, tachycardia, excessive sweating.
Immediate nursing interventions if NMS is suspected.
NMS is a medical emergency, first priority. Immediately discontinue the suspected drug. Supportive care focuses on rapidly reducing body temperature, cooling blankets, ice packs. Specific meds like bromocriptine, dopamine agonist, and dantrolene, muscle relaxant, are commonly used.
One final category listed, teratogenicity. Can you explain that?
Teratogenicity refers to a drug's capacity to reach a developing fetus embryo and cause harm, fetal death, or congenital defects, structural functional abnormalities at birth. Skeletal issues, CNS problems, heart defects.
Okay.
Effects vary by drug, dose, timing, and pregnancy. The full spectrum isn't always known.
So it's absolutely crucial for nurses to be aware of these risks when medicating women who are or might become pregnant.
Absolutely. Any pregnant patient needing drug therapy must be fully informed of fetal risks. Before giving any med, weigh maternal benefits versus fetal risks carefully. Advise strongly against self-medicating during pregnancy. Provide emotional physical support if facing potential fetal death or birth defects.
Yeah, it's truly sobering to realize the sheer breadth and variety of potential adverse drug reactions. Really underscores the complexity of pharmacology and medication administration.
It is sobering, but as we've discussed, it also highlights the absolutely critical role nurses play in medication safety. All medications have potential adverse effects. Your knowledge, keen observation, and vigilance in recognizing, managing, and preventing these reactions are essential for safe, effective care.
So just to summarize, we've covered primary actions, exaggerated effects, secondary actions, unintended effects, drug allergies, immune system involved, and a wide range of drug-induced tissue organ damage, skin, GI, liver, kidneys, blood. We also discussed disruptions to glucose and electrolyte balance, impacts on vision and hearing, various neurological effects, and the significant risks of teratogenicity.
And understanding these categories and manifestations is just the starting point, right? Continuous, thorough patient assessment, comprehensive patient education about side effects and when to seek help, and effective communication with the whole healthcare team are all absolutely essential for safe medication therapy and the best patient outcomes.
This has been a truly in-depth and incredibly informative deep dive. Considering the vast array of potential adverse drug reactions we've discussed, what strategies do you think are most effective in promoting overall medication safety and ultimately preventing harm to patients? It's definitely a critical question to keep thinking about as you continue your nursing journey. Thank you for joining us for this important discussion on the Deep Dive.